Welcome to yet another session of Marvelous Medicine. Today we have an interesting program on HPV. And then we have a very eminent speaker, Dr. Shalini Rajaram, who's the professor and program coordinator of MCH Gynecological Oncology program in the Department of OBGYN, AIMS Rishikesh. She is formerly Director Professor UCMS and GTPH Delhi, and she has many accolades, and she held many positions, which include past presidentship in the Association of Gynecological Oncologists India, 2019. She is the past president of Asia Oceania Research Organization on Genital Infections and Neoplasia India between years 2014-2017, and she was also the past president of Association of OBGYN Delhi, 2017-18, and she is the president presently of Society for Vaginal Surgeons Delhi, and former chairperson of AOGD Oncology Committee, member of FOGC Oncology Committee between 2015 and 21. She is the editor of the Indian Journal of Gynecological Oncology, a member of the International Gynecological Cancer Society, European Society of Gynecological Oncology. She is author of 16 books. 2 of them have been translated into Spanish, and she has also written 3 books on gynecological oncology. She has authored, co-authored more than 50 articles, and she has published more than 150 journal publications and many chapters, more than 100 chapters in books, and she's given keynote orations of more than, and guest lectures of over 250. And she's a keen orator and is a dedicated teacher, a gynae oncosurgeon, and a laparoscopy individual surgeon. I think we are very privileged to have you, ma'am, today on this program, and in the wonderful CV. And to moderate this session, we have, hopefully we'll have Dr. Priya Abraham, who's Professor of Clinical Virology in CMC Vellore, India, and she's a member of the IAMM, ISCR, and AOGINI in India, and she has over 210 publications, and she's earlier Director of National Institute of Virology, Pune, between 2019 and 22, and her interests are in the region of hepatitis virus and HPV. And then we also have, as was just commented by Dr. Shalini, one of the most eminent gynecological oncologists in the country, Dr. Abraham, and he is presently a senior consultant in gynecological oncology in Naruvi Hospital, Vellore, India. He has over 108 publications, and he was earlier the professor and head of gynecological oncology at CMC Vellore, and is also the past president of AGOI and AGOI in India. Welcome, and Dr. Shalini and Dr. Abraham, and now it's over to Dr. Shalini to begin her session.
So, can I share my screen?
Yes, please.
Oh no. Something happened. 1 second.
Yeah, do it again.
It's disappeared now from my screen. 1 second. Let me just. Is it seen?
Yes, we can.
Okay. Yeah. So as I said, I don't know how I was dragged into giving this talk by Dr. Vidya, who you can't say no to. And I thought I'll speak something which would be of interest to everybody in the group, like the general surgeons and the other doctors in the group, and not be very subject specific. So I thought I'll speak on HPV related disease in men and women. Although it's more seen that we always talk about HPV and cervical cancer, but it also causes a host of other cancers in men and women. And it is at least my dream in my lifetime to see an elimination of cervical cancer, because this cancer is quite a dreaded disease. It affects women in the prime of their lives when their children are growing up, and it totally disrupts families. And I think in today's day and age, with the technology, with vaccinations, etc., we should be able to eliminate this disease. So the HPV virus is a very ubiquitous virus. It is very, very common. It's like the common cold, so you can get it quite easily. And they're small, non-enveloped, double-stranded DNA viruses with a circular DNA genome encoding for about 8 open reading frames. And they have a capsid, which is an icosahedral capsid. And they have a predilection to affect the mucosal and cutaneous epithelium. So they are epitheliotropic viruses. So when we, today, I think I'll be confining myself to mucosal and genital infections. There are more than 100 different types of HPV viruses. Maybe about 50 of them are low risk and high risk, which affect humans. And of these, the important ones are the low-risk viruses, which cause genital warts and anogenital warts, recurrent respiratory papillomatosis, etc. And they can be very, very distressing, very, very disturbing. They can grow to large sizes, especially in pregnancy. So even though they may not be cancer, they are a very distressing condition. And then we have the high-risk viruses, of which 16 and 18 are the most aggressive. And you have the other viruses like 31, 33, 45, 52, so on and so forth, about 14 of them. So these can cause not only a high-grade and low-grade pre-invasive cancers, but also 7 other cancers, which we'll talk about a little later. And the non-mucosal cutaneous infections are called the plantar warts, palmar warts, like other skin warts, which are not, may not be pre-invasive or invasive, but they are very, very infectious. So the HPV tissue tropism, we talk about cutaneous warts, and they're typically called the butcher's warts because if about 30% or 40% are found in butchers or people from the meat packaging industry, probably a zoonotic spread. And then we have the genital warts or the condyloma acuminata, which is caused by 6 and 11. And this, fortunately, is present in the HPV vaccines that we have today. And we'll see about the real world data of what has happened after starting the HPV vaccination. And cervical, vulvar, vaginal, anal, and penile are the other cancers. HPV 16 per se is the most important type of vaccine, which is more persistent, which is more aggressive, which kind of integrates into the human genome much more than the other viruses. And HPV 16 is also an important cause of squamous cell carcinoma of the oral cavity. And oral cavity cancers are probably 40% or 50% of them are due to HPV viruses. So some facts about HPV: it affects both men and women, not only women. Typically 15 to 24-year-olds, therefore we need to target this group of adults. It's very easy for us to sermonize and patronize and tell them not to do this and not to do that. But adolescents, as adolescents are, will go on to doing whatever they want to. They have the raging hormones. So I think apart from education and awareness to this group of young adults, we need to protect them adequately with vaccinations. Then HPV, we already said it causes genital warts and various other cancers. And it spreads not just by, yes, it's a sexual route that is important, but even skin-to-skin contact, genital-to-genital contact, kissing, and non-penetrative sex can also spread HPV virus because it's an epitheliotropic virus transmitted via the epithelium. So about 4 out of 5 women at some point in their life will get infected with HPV. Likewise, 4 out of 5 men also will get infected with HPV virus at some point in their life. Fortunately for women, we do have a screening test, which is done between 30 to 64 years, but in men, there are no HPV tests. So probably HPV is the most common sexually transmitted infection. And but transmission is more through skin-to-skin contact rather than only penetrative sex. So warts is the other disturbing condition that is caused by HPV viruses. So when you look at the men and women, you have 7 different types of cancers caused by HPV virus. That is the mouth, upper throat, or this is the base of the tongue and the oropharynx. Cervix, of course, 99% of all cervical cancers are HPV related. A lesser proportion of vaginal cancers, maybe about 40 to 50% of vulval cancers. Anal cancers, again, about 80 to 90% is due to HPV virus, especially in men having sex with men and homosexuals, etc., and also in women who are affected by this virus in their genital tract. And the penis also, I think it's about 60% of penile cancers are due to HPV virus today. And the incidence of HPV, especially for vulvar cancers, is increasing because of the HPV virus. And definitely in India too, we have more sexual freedom nowadays. So you do have more HPV infections. So 16 and 18 are the most important type. The other 2 types which are important, like 16 and 18 cause about 70% of cancers, and 31 and 45 are said to cause the other 25 to 30%. The other types of viruses are also seen. You can, if they're detected, you follow them up, but they may not be as aggressive. But the best part about HPV virus, it is you get infected between 20 to 30 years of age, and majority of them regress. So infection doesn't mean you have cancer, but we do not know which woman is going to progress and which woman is going to regress, or which man is going to progress and in which man the HPV virus is going to regress. And therefore everybody needs to be protected. So apart from the cancers, you have the recurrent respiratory papillomatosis and Bowen's disease, which is a disease of the skin, again caused by HPV 16, 18, etc. Bowen's disease also occurs in the vulva. And these are other cancers which are caused by HPV virus. So you can see the oral cavity or the oropharynx of which has these tonsillar crypts. And just like we see in cervical cancer, you have proliferation of the virus in the basal layer first, and then the entire epithelium is affected and the virus is shed, and then you go on to infecting other people. And then if you are not able to clear it yourself, it goes on to becoming dysplastic and carcinoma in situ and invasive cancer. And you can imagine how difficult it would be to treat these oropharyngeal cancers, because the area is very wide. These tonsillar crypts, it's a wide area. Maybe cervix may be easier to treat because it's a smaller area if you pick it up early. Then we have the recurrent respiratory papillomatosis. I'm not sure many of you are anesthetists here. How often do you see them? But I know of a girl, a patient of mine, who had acquired it when she was acquired it during childbirth, like when she was being delivered, I think, from her mom. And then she had several surgeries and a tracheostomy. The surgeries going on till she was a teenager before these warts could be completely removed or completely ablated. So it is not something that we say it is a benign disease. It is benign, but it can be very, very troublesome. And this girl now has a very hoarse voice, and because of the multiple surgeries that were done or ablative techniques to remove the warts. So they are troublesome lesions. So the cutaneous warts we talked about earlier, which are not due to these high risk or low risk viruses. Then we have the cervical lesions. You have vaginal, cervical, vulvar lesions. This is anal cancer, and these are some pictures of penile warts. So the risk factors that we said was sexual activity. That is probably the most important risk factor. But even immunocompromised states such as renal transplants or any liver transplants, or people who are living with HIV, they are all in immunocompromised states, and they develop HPV infections, or they acquire HPV infections much more commonly, which progress on to becoming pre-invasive and invasive cancers. And therefore, these people should be screened at least once a year. And smoking is another risk factor, multiple sex partners. But we know today that HPV 16 and 18 is the essential cause of cervical cancer. And additional factors like early age at sexual intercourse, number of childbirths, multiparity, etc., probably are only cofactors, which cause the abrasions in the cervical epithelium, leading to infection and later on transformation. So coming to anal cancer, I thought I'll just talk a little bit about these three cancers before going on to these cervical cancers. So the anal cancer is similar to genital malignancies rather than to GI malignancies. The risk factors was HIV, males having sex with males, females diagnosed with HPV virus, or having precursor lesions, solid organ transplant recipients, and immunosuppressed individuals. Then squamous cell carcinoma is the predominant histology and strongly associated with HPV infection. Symptoms are pressure, pain in the anus or rectum, change in bowel habits, a lump near the anus, rectal bleeding, etc. And chemoradiation is the standard of treatment in early disease. Chemoradiation, normally we say early disease, it's surgical interventions, but in anal cancers, because it involves the anal sphincter, if the anal sphincter is gone, she will need to have maybe a stoma, or she will have incontinence, and therefore chemoradiation is the treatment of choice for early stage anal cancers, with surgical intervention reserved for salvage therapy. And the median survival rates for these patients with metastasis ranges from 8 to 34 months. Coming to penile cancers, it is more common in resource-limited areas of the world, such as Africa, Asia, South America, and they account for approximately 10 to 20% of penile malignancies in males. Disease of older males, and it increases with age. So risk factors are genital warts, chronic penile rash, UTI, phimosis, obesity, HPV. I think the surgeons will be able to tell us better about penile cancers. And the prognosis is dismal. The prognosis, 5-year survival for all stages of penile cancer is about 50%. So normally they say that HPV-associated cancers have a good prognosis. They're better than other cancers. But maybe this is for all kinds of penile cancer. Then you have the HPV-associated oropharyngeal cancer, and they say that it is the highest in high-income countries. Though the epidemiological data from low and middle-income countries is not there, I think most of our oral cancers are because of tobacco and tobacco chewing or pan masala, etc. But we really don't know what is the contribution of HPV to oropharyngeal cancers. So it is similar, like I showed you that a picture of the tonsillar crypts. It is similar to the biology and genomic features are similar to those of other HPV-associated malignancies. So they can present with a neck mass or a sore throat, dysphagia, odynophagia, otalgia, etc. And the substantially better prognosis of patients with HPV-associated oropharyngeal cancers compared to negative ones has been recognized by the American Joint Committee on Cancer. That is a TNM classification, the people who have given the TNM classification. So basically, it takes a long time for the HPV to progress to cancers. You have a long intervals, maybe about 5 to 10 years after acquiring the infection. So you acquire the infection early in life, which remains dormant in the basal layer. And they can either progress or regress. Majority of CIN1 do regress, so you can even follow up CIN1 patients. But large number of CIN2 or CIN3 patients progress to cervical cancer. And you can just notice that HPV DNA levels decrease. So maybe in a full-blown cervical cancer, you may not find the HPV DNA, but then you will have your block positivity of P16, etc. And then E6, E7, mRNA levels increase because E6, E7 are viral proteins, which are the transforming proteins. And this allows integration of the HPV virus into the human genome. So looking at now coming to cervical cancer, we know that it is the second most common cancer in females. So the first being breast cancer, and about 123,000 cases are were added in 2020, mortality being about 77,000. So you can see that we contribute about 20% of the world's burden of cervical cancer and 22% of the deaths due to cervical cancer. We have about 483 million women who are at risk of developing cervical cancer. So we need to protect them earlier on when they were young, they're young kids, or at this point of time by screening for cervical cancer. And the lifetime risk is 1 in 75 Indian women will develop cervical cancer sometime in her lifetime. So I like this picture. It's an older picture. It's an equal area cartogram, which sizes a nation according to the load of disease. So you can see India bloated, very frightening to see India bloated like that with the number of cervical cancer cases. And you can see Australia is completely wiped off the map because they had a very good screening program earlier, and now the vaccination program is very good. So this kind of a cartogram sizes a country according to its disease burden, and this is for cervical cancer. So we have some new data, and we've also seen that although the incidence rate may be decreasing, the incidence right now is 14 to 18 per 100,000. Earlier, when we were students, it used to be roughly around 40 per 100,000. And Salem in Tamil Nadu had the highest rate of 99 per 100,000. I think somewhere is highest in the world. But Tamil Nadu has done very well in bringing down the incidence of cervical cancer because the screening program is available in almost all of their primary health centers, and they're probably going to start the vaccination too. But India's population has surpassed that of China. So since we have surpassed the population of China, the number of cases, even though we say that the cervical cancer incidence is decreasing, the projected number of women in 2022 is going to be 79,000, which is more than it was in 2020. And in 2025, the projected incidence of cervical cancer is roughly 85,241. So by mere population size, our numbers will be increasing, though the incidence, at least epidemiologically, there's no answer to why the incidence is coming down despite not having any regular screening programs or even the vaccination program. So this is Harold Zorhausen, who's a German virologist, and he received the Nobel Prize in 2008 when he was 72 years old for his discovery that the human papillomavirus is the essential cause of cervical cancer. And he showed the infection and how the virus gets integrated. And you have these two viral proteins, E6, which abrogates P53, decreases apoptosis, and therefore there is accumulation of oncogenic cells. And E7 binds with retinoblastoma protein and releases the P16 actually from the cell cycle control. So it's a cell cycle checkpoint inhibitor, and this leads to proliferation of cells. So you have a long interval in which you can actually prevent cancers. Something we call primary prevention is before the HPV virus actually enters the basal epithelium of the cervical epithelium. So that's primary prevention. And then you have secondary prevention, that is the virus is there, it is proliferating, but you can pick it up because it takes about 5 to 10 years for it to progress to cancers by regular screening. But no screening test is perfect. So probably primary prevention would be a better method for prevention rather than secondary prevention. And tertiary prevention is something WHO has introduced, saying that all women who are detected to have pre-invasive cancers or cancers must be treated. So this is what the WHO said in 2018 when they realized that you had very effective tests, you had very effective prevention programs, yet the rest of the world, or there were a lot of inequalities in the rest of the world. So there's they've set some targets for us for countries. I think India is also part of this program, or and India has endorsed this. And we need to eliminate cervical cancer. By elimination, we mean reducing it to less than 4 per 100,000. So if 90% of girls are fully vaccinated by 15 years of age, 70% of women are screened with an HPV test between 35 to 45 years of age, and 90% of women who have cervical disease are treated, we should expect a reduction in mortality from cervical cancer by 2030 of 30%. But for it to completely be eliminated, it's going to take at least 50, 60 years more. So 3 strategies, 1 goal: vaccinate, screen and treat precancerous lesions, and integrate treatment and palliative care into early on. So because what happened now that we've started screening, a lot of states have started screening, but they're not able to handle these screen positives. So once the patients are screen positive, they have either low grade or high grade dysplasias, they don't have enough treatment facilities. So I think treatment facilities are going to be have to be integrated into screening centers so that you can treat at the same time, especially lesions that are amenable to ablative treatments. Then this is a modeling study which says that implementation of the strategy that is both cervical cancer vaccination and screening can prevent 60 million deaths due to cervical cancer, 45 million deaths due to cervical cancer over the next 100 years. So it is a leap onto faith, I think. We'll have to wait for maybe 50, 60 years to actually see a decline if we start doing things correctly right now. So talking about natural infection, you might say, like if you say HPV virus is so common, we are all immune to it, but that doesn't happen. Doesn't happen because the HPV virus doesn't expose itself to the circulatory system or to the blood vessels. It's just lying in the basal layer of the epithelium, and therefore there is no antibody response. So there's a very poor antibody response, which is not sufficient to prevent the HPV virus from proliferating. So the naturally acquired infections, many people might get rid of themselves in a couple of years, but strictly speaking, the natural infection has very low antibody responses, low titer antibody responses in women, and men, very few men seroconvert. So, and they have less response to natural HPV infections, and the antibodies and any antibodies that men produce may not be protective. So men have to be protected too, but we'll see why women are being advocated the vaccine and not men in all countries. We'll have a look at it. So the first vaccine for prevention of HPV-related disease was licensed in 2006. So that's almost 17 years back. And 125 countries worldwide have introduced HPV vaccine into their national immunization program. And about 47 countries also for boys. So initially, basically, they said the girls need to be protected because the incidence of cervical cancer was very high, and the other diseases in boys was not so high. So that was not, I'm not sure if that was the right thing to say, but there was a problem in vaccine production. There was a problem in the cost. So to be most cost effective, it was advocated only in girls. But they said this was science which said that if you vaccinate girls, the herd immunity will also increase and the boys will be protected. But I'm not sure if that's the right way to go about it, but this was done earlier. But now most countries have introduced vaccination for boys too, especially because boys cannot be screened and boys are carriers for the HPV virus. So it's important to vaccinate boys because they cannot be screened. And they are safe viruses. They do not contain any live biological products. They're non-infectious. They contain viral-like proteins, which are against HPV 16 and 18. And in fact, this HPV vaccine was innovated in Australia by Ian Fraser. And the then wife of the Prime Minister had suffered from cervical cancer. So they really encouraged the science behind HPV, the vaccines and the testing early on in Australia. Then we have two kinds of vaccines which are available in India today. We have the quadrivalent vaccine and the nonavalent vaccine. The quadrivalent vaccine protects against 6, 11, 16, and 18, which is 6 and 11 are for the warts and 16 and 18 are for the aggressive nature of these viruses. Whereas a nonavalent vaccine, in addition to these four, also protects against 31, 45, 52, and 58. So there are 9 types that it protects against. And after 16 and 18, 31 and 45 are supposed to be the next most important viral types in the cause of cancers. So the WHO recommends the vaccination to be given to all girls between 9 to 14 years of age. This is a WHO recommendation. And as and when the country can afford to vaccinate everybody, even boys between 9 and 14 should be vaccinated. Right now, they are the secondary targets. Boys are the secondary targets, but they are licensed for use for boys in India. So whoever can afford it, I think should get their boys vaccinated too. Earlier, it was not licensed for boys. The bivalent and the quadrivalent, but the nonavalent vaccine and the new indigenous vaccine are licensed for boys too. And immunocompromised people, especially those living with HIV or children and adolescents who face sexual abuse, must be a priority group and they must be vaccinated. So 9 to 14 years, the WHO recommends 1 or 2 doses. They say 1 dose will be cost effective because you can protect a large number of girls. But they've given it as a recommendation which is which is slightly ambiguous. But many countries like the UK and Australia have started following the single dose vaccine. And at least 2 doses after 15 to 20 years, but this is changing. There are a lot of controversies on whether you give 1 dose or 2 doses, but probably some countries have adopted the single dose vaccine for children between 9 to 14 years, but WHO even recommends single dose for 15 to 20 years. And after 21 years, it's for at least 2 doses. So the types of vaccines which are available worldwide, which are WHO approved, are the Cervarix, which is a bivalent vaccine for only 16 and 18. And that was initially available in India, but it is no longer available in India. They've stopped manufacturing it here, but it's available, I think, UK uses Cervarix. And Secolin and Volrinax are Chinese vaccines. These are bivalent vaccines and available in China. Gardasil and Gardasil 9. Gardasil is a quadrivalent vaccine and Gardasil 9 is a nonavalent vaccine. These are produced by Merck and they are available in India at a cost. Gardasil costs about 3,000 rupees per dose and Gardasil 9 costs about 9,000 rupees per dose. And the indigenous Indian vaccine is the Cervavac, which is a quadrivalent vaccine. Right now it is for boys and girls between 9 to 14 years, where they advise 2 doses, and for more than 15 years, 3 doses. So this was first launched in March 2023. It's not yet come into the National Immunization Program. Probably they keep postponing it. They said November, now they said May, and then June. But I think it's going to start. But Cervavac is available commercially. It's available commercially. And it protects against 4 subtypes. It protects against genital warts. It has a robust antibody response. And the geometric mean fold rise is about 1,000-fold in men and women between 9 to 26 years of age. So this vaccine is available commercially for rupees 2,000 a dose. But it's a very silly packaging. You have 2 doses in 1 vial. So you have to find 2 people to give it to them. So, I talked to the Serum Institute of India guys, and they'll change that, and they'll also bring down the cost, because earlier when Adar Poonawalla had launched it, they said it will be available for 400 to 500 rupees, but they've kind of cheated us, and it's about 2,000 rupees a dose. So over 48 crore women in India, age 15 and above, are at risk of developing cancer. So, but majority remain unvaccinated. It's available, and maybe don't buy a sari or some clothes, or don't go to an expensive restaurant and get vaccinated. So cervical HPV vaccination protects against 6 types of cancer. Cervical cancer is 11,000, 1,96,000. This is in the US. This is not our figures. And the other cancers are the oral, anus, vulva, penis, and vagina. For us, these numbers are much, much higher. Cervical cancer itself is about 77,000. Precancers will be at least 10 times more. So for us, in terms of numbers, much more cancers and precancers can be prevented by the vaccination. So the Indian vaccination program has requested 7 states to start preparations for rollout of the HPV vaccine for girls between 9 to 14 years. First of the 3 phases in India's planned introduction. Then it will become, for the first few years, they want to give it to age 9 to 14, and then all 9-year-old children or 10-year-old children will get vaccinated. So in Maharashtra, Chhattisgarh, and Karnataka, they're going to start with a 2-dose schedule. And they've allowed states like Mizoram, Uttarakhand, Himachal, and Tamil Nadu, based on science, based on other countries switching over, based on good immune response, even 1 dose. These 4 states may start with a 1-dose schedule. Not yet started, but will be started soon. So even a single dose is protective, is what WHO says. And they said a single dose schedule provides comparable efficacy to 2 or 3 dose regimes. And systematic reviews have shown seropositivity among subjects who receive 1 dose to be non-inferior to that after 2 or more doses. So a single dose schedule can be used for girls and boys aged 9 to 20 years. And many countries like Albania, Australia, Cabo Verde, I haven't even heard of this country, Ireland, Solomon Islands, Tonga, UK, Mexico have all switched over to the single dose vaccine. So by 2020, I can't even see myself, by another set of states and union territories will be covered by 2024 and 2025. So in the end, they want to vaccinate 68 million girls against HPV, a further 11.2. So suppose you vaccinate all this cohort of 68 million girls between 9 to 14 years, then every year you will just have to vaccinate 11 million girls aged 9 years and above. So assuming a 90% vaccination coverage in girls aged 10 years, HPV vaccination could effectively reduce the prevalence of 16 and 18 by 97% in 50 years. And then we might reach the threshold for elimination, which is 4 per 100,000 women. My slide is not moving. Okay. So basically, the nonavalent vaccine, anybody who's hypersensitive to yeast should not get the nonavalent vaccine. And other contraindications if you are allergic, prior allergy or pregnancy. Then side effects are few. The side effects are mostly local reactions at the site of injection, some amount of pain, and maybe a little bit of fever. But nothing more than this. I think more than 120 million doses of vaccine have been given worldwide, and there have been no serious side effects. But when you want to inject the girl, I think she should be had her breakfast. She should be sitting down and not standing up, or maybe lying down when you give her the vaccine, and let her lie down for about 15 minutes. So some precautions so that when the vaccine rollout happens, there are no problems. And of course, we know that anybody with any acute fever or any acute illness should not receive the vaccine at that point of time. And a missed dose is even if you missed a dose, because now single dose is saying is sufficient from 9 to 20 years of age. But if you missed a dose, you can take it anytime, and you can use any other vaccine also that is available to complete the schedule. So if you look at the real world data on cervical cancers, you find that following 5 to 8 years of vaccination amongst girls 13 to 19 years, there was a significant decrease in prevalence of 16, 18, and other HPV types, anogenital warts up to 67%, and CIN2 plus lesions of 51%. So in Australia, they have the 3-dose vaccine since 2007. It was extended to the young male population in 2013. And the prevalence came down from 28% to 2.3% in women aged 18 to 24. That is the prevalence of HPV virus. And from 18 to 7% in men by the end of 2015. So incidence of high-grade abnormalities in women aged 20 years have decreased, and 5 per 1,000 women by 2014, less than half the rate. So basically, this was maybe in the 90s and early 2000s, before the vaccination was introduced into Australia. A friend of mine had gone to Australia to work in Australia, and he said he was amazed to see the number of girls waiting for treatment for pre-invasive cancers. That is, we call the procedure LEAP. They used to be waiting 7 to 10 girls waiting in every OT for some kind of treatment for their cervical precancers. And today, those girls, that's disappeared. After the vaccination has started, you hardly find any woman coming in for treatment for pre-invasive lesions. Likewise, in Sweden, they have had quadrivalent vaccine since 2006. And the incidence rate decreased by 88% in women less than 17 years. So if you have to vaccinate, I think the best time to vaccinate is adolescents. It's an adolescent vaccine, and they have the most robust immune response. See, if you see that women who are vaccinated after 17 years, the decline was, or the incidence rate of cervical cancer declined by 53% only. So the earlier you vaccinate, the better it is, because the immune response is much better. Then the takeaways are, we have 2 types of vaccines available in India today. The primary target group is 9 to 14 years. 2-dose schedule, at least for Cervovac, is what is now recommended. Maybe it'll change later on. Secondary target group are girls over 15 years. All boys come at this point of time into the secondary target group. HIV positive women, sexually abused children and adolescents, and they require at least 3 doses. And it protects against 7 types of cancers and anogenital warts in men and women. More important to target the men also, because we don't have any screening tests for them. And real world data has shown a decrease in prevalence of HPV 16, 18, and other HPV types following introduction of vaccination. Now, coming to screening, we can't ignore screening because vaccination has come in. We'll have to continue screening because a lot of our women have not been vaccinated. So screening also the paradigm, there has been a paradigm shift in the screening from what we did earlier. So the PAP test is kind of retired now. We've retired the PAP test, or maybe use it only for triaging. And there are other tests which are more important now because we know now that HPV is the cause of cervical cancer, or the high-risk HPV is the cause of cervical cancer. And the principle of screening, as we know that cervical cancer, unfortunately, has no symptoms until she comes to us with advanced cancers. So by the time she has telltale symptoms of postcoital bleeding or some kind of spotting, it's already too late because she already would be having maybe a high-grade lesion or even a cervical cancer. That's the reason we need to screen asymptomatic women. So we screen, even though she has no symptoms in the United States, in the United Kingdom, maybe less in Europe, it's like clockwork that they go for their screening tests regularly. Whereas in India, if you ask women to get screened, "Mere ko kya hua? Main to bilkul theek hu. Mere ko to kaise hoga cancer?" So that's the answers we receive from Indian women who do not want to get screened. And once they're screened, and even if they're positive, they don't believe that anything is wrong with them because they are perfectly normal. So anyway, the principle of screening is to identify pre-invasive lesions and cause no harm during treatment and follow-up. So this we said, HPV virus is the essential cause of cervical cancer. There's a long period from which from infection to cancers that it takes a long time. Therefore, we have this long window of so many years during a woman's life in which we can screen her and pick up pre-invasive disease or early cancers. Of course, we would like them not to get the infection at all, but we still have screening tests which can pick it up early. So the target age group in India by the government of India is 30 to 65 years, but WHO now has said we should screen women between 30 to 49 years. That's the most captive age to treat. But in India, we still have women having cancers after 60 years or even older women. But the majority of women who are affected by cervical cancer are between maybe 35 to 50 years of age. There's a little film clip which I'll show you later because it's terrible to see young women walking into your OPD. They look hale and hearty like you and me. And when you examine them, you are surprised to see a large growth, and they're not even aware that they have growth inside. So the test today that we recommend, or WHO recommends, and the world recommends, is primary HPV DNA testing. The PAP test can be done, a liquid-based cytology can be done, but these tests are imperfect tests because the sensitivity of a conventional PAP is only about 50%, because what you're taking may just be debris, maybe just some infective cells, and you may be missing the cells in question. And liquid-based cytology makes the smears more satisfactory, but it has not improved the sensitivity. And visual inspection with acetic acid is a test for us, for India, which is very simple to do, which is easy to do, and it is not an expensive test. But of course, the woman has to come and lie on the couch and be screened. So the HPV test, most of the cancers, 99% of cervical cancers are attributed to this. So we have various kinds of HPV tests, and even the WHO recommends using HPV DNA for primary screening rather than VIA or cytology. So why HPV testing? It has a higher sensitivity, but a lot of people get alarmed that they have an HPV infection, but not all HPV infections are cancerous, but you can follow them up at least. Once you know that they're positive, they can be followed up. And if they come for regular screening, we can pick it up. So HPV testing has a higher sensitivity, but lower specificity than cytology. So cytology is a good test to triage. Once she is HPV positive, we can triage them to see whether there are any cellular abnormalities. And multicentric RCTs have demonstrated HPV testing provided 60 to 70% greater protection against invasive cancers compared to cytology. And in fact, there was a study by Dr. Shankar Narayanan in probably the early 2000s, in which they showed a single round of HPV testing in about 30,000 women in Maharashtra, did decrease deaths due to cervical cancer more than VIA or cytology did. This is when they, again, rescreened after 5 years, or when they had the data after 5 years. So most of the tests are DNA. It's a DNA virus, so the tests are DNA-based tests, HPV DNA-based tests. But you have HPV mRNA tests, which study the expression of E6 and E7 oncoproteins. These are the transforming proteins. So the various tests that are available and approved by FDA: hybrid capture 2, care HPV, Cervista, COBA, Saptima, Protect, etc. All these tests are available in India, a little expensive. Hybrid capture maybe 1,500 to 2,000 rupees. COBA's test is good because it will tell you if it's high risk HPV positive and whether it's 16, 18 positive in a different channel. So this is something you can screen, or you can follow up women with 16, 18 much more stringently than you would follow up the women with other viruses. So earlier we were using a hybrid capture 2. But I think point of care test is something we need to shift to, because you don't have to do 200 tests or 99 tests at one time. You can do 3 or 4 tests at one time. And India has a lot of these small machines, which was used during the COVID times. And also for tuberculosis, we use these point of care HPV testing, point of care tests, which are available in all PHCs, in all small centers, government centers. And Uttarakhand itself has about 15,000 TrueNat machines. So TrueNat testing is again a point of care test, like the Gene Expert. And it is done, it is a made in India test by Ball Biodiagnostics. It's a portable chip-based test, and you get the result within about 1 hour's time. And it's a semi-quantitative estimation for 16, 18, 31, and 45. The most important viruses causing cervical, viral subtypes causing cervical cancer. So we did a study at AIIMS Rishikesh. We went into the community and we studied about 975 women. Very interesting to go into the community, because when you go and talk to the village panchayats and the elected leader there, I expected to see some old guy sitting on a khatia smoking a hookah or something. But you had these young, educated guys who were leaders, who were engineers, were leaders, and they're very interested in the health of their women. And they did organize the schools for us, and they did organize the women coming in. They said, you come around 11 o'clock, 12 o'clock, the woman would have been finished with their work, and then they will come for the screening. So it was a very satisfying experience, which we conducted the study between 2020 to June 2022, using self-sampling. We didn't have to arrange a table or a light source or speculums. So this was a vaginal sample collected by the patient herself. We showed them pictures, we counseled them on how to take the sample. And this test was done, a TrueNat testing was done. And later on, we validated the positive samples using another kit. And 44 out of 45 of the women who tested positive with the TrueNat test were tested positive by the other RT-PCR test too. So we had saw a prevalence rate of 4.6%. But what was surprising is, despite all the counseling, the education, and post-counseling sessions that we had with these patients, only about 25 women turned up for treatment. We didn't do a screen and treat approach. We call them back to AIIMS Rishikesh, and did the triaging with the pap test and colposcopy. But 50%, almost 50% did not come back, because they say there's nothing wrong with me. We've gone to another gynecologist. She saw us and they said everything is okay, nothing is wrong. And they didn't come back. But later on, another 5 or 6 people came. And these were patients who had high-risk squamous intraepithelial lesion. So it's very difficult unless you have everything under one roof at one time to treat these patients. But self-sampling was very satisfying to most of the women, and they found it comfortable, and they said they would strongly recommend it to other eligible women. So point of care testing is the way to go in the community, and self-sampling is acceptable, but the government has to do something about this now and see that screening is available in every primary health center. So what is recommended by WHO and by FOXI is you screen women from the time they're 30 years old with an HPV test. If you're using a cytology, you may do it earlier, but India recommends it from 30 to 65 years and using either HPV DNA, that is by the FOXI recommendation, whereas India says visual inspection with acetic acid. And WHO says you can screen even once in 5 to 10 years. They stop at 50 years, while Indian recommendations are 65 years. And for HIV population, you start it earlier and maybe do it every 2 to 3 years, the HPV DNA testing again. So visual inspection with acetic acid is you apply acetic acid, which is vinegar, dilute vinegar, and then you have these lesions which show up after application. So it's very easy for even paramedical workers. In fact, we've started a nurse-led VIA training initiative. It's very easy for them to look and pick up these lesions. But of course, you need quality training, quality assurance, because a lot of inflammatory lesions can also appear white, and you might mistake them for dysplasia. And therefore, the positivity rate is, or the false positivity with VIA is a little high. The PAP test, as we said, requires good infrastructure, good cytopathologists. It is cumbersome. The patient has to lie down, and by the time you take the sample, you might have drying artifacts, etc. It's a good test if you do in good hands and good for triaging, but maybe not for community screening or not screening a large section of the population. So in the West, everybody switched to liquid-based cytology. So they use liquid-based cytology, but even this, they moved on to primary HPV testing in most countries of the world. Then the last terminology, I thought I'll just tell you a bit about the last terminology. Last is lower anogenital squamous terminology. So for everything from the cervix to vagina to the vulva and the anus, you use only two terms, LCIL and HCIL. This is for biopsy, cytology for everything. LCIL is low-grade squamous intraepithelial lesion, and HCIL is high-grade squamous intraepithelial lesion. So the last terminology is what is used today by WHO for cancers of the cervix, vagina, vulva, and anus. So coming to tertiary prevention is a universal colposcopy, of course, is a universal diagnostic tool where you want to diagnose women who have an abnormal screening test. Not every woman will do a colposcopy, the ones with abnormal screening tests, and then biopsies, and then we treat the lesion. So that is tertiary prevention. So today you have a lot of devices in the market, even AI-enabled devices. You don't have to do any thinking. You don't have to do any looking at it. It will look at the cervix, take pictures, and tell you what the disease is. So AI is replacing everything, including even our clinical sense and the ability to identify lesions. So you don't have to do anything. So it's going to already I think our kids are more used to looking at MRIs and CTs and rather than examining the patient. So those little skills that we have are going to vanish. So these are the various methods of treatment that are used: thermal ablation, cryo, loop, and cold knife conization. So in cryotherapy, you freeze the cervix as a transformation zone with using nitrous oxide, and there's intracellular crystallization of water and necrosis of cells. But even this equipment is not easy to use in the sense that there's a gas leak from various sites. There can be a gas leak. I don't know why till today they've not perfected the good cryotherapy machine. And then you have this bother of carrying cylinders. If you're going into the community, cylinders have to be filled, etc. So this is slowly going or replaced by thermal ablation, in which you have this Teflon coated probe, which is just heated to 100 degrees or 120 degrees and applied on the cervix. It is not electrocautery, it is just heating, and then it destroys the epithelium to about 5 to 7 millimeters. And this probe can be used on 3, or even if the cervix has a large zone which has to be ablated, you can use it in 4 or 5 sittings and ablate the transformation zone, as we call it. And then we have something called the LEAP, or the loop electrosurgical excision procedure. And if the English call it the LLETZ, which is a large loop excision of transformation zone. The Americans want to be different and call it the LEAP. And it is widely used. In fact, in America, they don't even use ablation. They directly use the LEAP, which is a thin wire loop, which is used to excise the transformation zone using cautery, electrocautery. But the wire loop is so fine that you do not have any charring artifacts or charring artifacts. So conization is the traditional cone where we remove the transformation zone along with the endocervix and using a knife, because especially if the disease was extending more into the cervical canal, it's difficult to use wire loop. But now they have something called a Fisher's cone, which is a thin wire loop of the with which we can do a conization. Then, of course, treatment goes to surgery and radiotherapy, chemoradiation. But whatever you do in advanced cancers, the survival falls, and there are chances of recurrences and other things. So it's better to prevent it rather than come to the stage that you have to treat a cancer. So screening takeaways necessary to identify pre-invasive lesion, and you have this long window of opportunity. And it is the modality for primary screening for whoever can afford it, and VIA for limited resource settings. Point of care tests, which are affordable will be the way to go for community screening. And they can be easily managed by thermal ablation, cryo, and excisional procedures, but has to be managed properly, because if it's not managed properly, they'll come back with recurrences. And invasive cancer is difficult to manage. Only stage 1 cancers we can operate at is only up to 1B2, and the rest of the cancers need chemotherapy and radiation. So I just thought I'll show you this a cancer survivor.
Shalini, we can't hear the audio.
Oh, what do I do? What do I do?
Is your volume on maximum?
I'll just check 1 second.
Or maybe you can just give the voiceover of what's being said.
Okay, yeah, I'll do that. So basically, say in this, showing you all this clip. Is it heard now? No. Is it heard now?
No, I can't.
Okay. Okay, so basically she's a young lady, about 50 years old, and she comes from a well-to-do family, and she had some bleeding. And when she went to the doctor, her father-in-law worked at Gangaram Hospital, and she went there and diagnosed with cancer. And she was okay. She was ready to fight it, and she was treated. She had a surgery. But in 3 months' time, her test was again positive. So that shook her. But then she underwent chemoradiation, chemotherapy. She's okay now, and but even she, I don't know, I thought being an educated lady, never had any screening before, and only when she had symptoms she went for treatment. So if this is the state with us educated women, then you can imagine what it is for the people in the villages and less educated people. And then her daughters also probably were in their early 20s, and at that point of time she got them vaccinated. Just to tell you all that it strikes in the prime of your life, and we need to fight it probably with or prevent it with vaccination. So I'll just stop this. So we have a nurse-led VI training initiative which is started. I've trained about 125 nurses in the in Uttarakhand state. About 25 of our nurses have been trained. So they're going to start it at our hospital. And use VIA because it is the most cost-effective method, and you don't really need too much of an infrastructure. And they not only are going to create awareness, but they're also going to create awareness of vaccination through the mothers who come for screening. And they will also navigate the VIA positive women, because right now wo bhatakte rehte hai. So navigators or KWATs are, I think Tata Memorial Hospital started it initially. So any VIA positive woman, they will navigate till confirmatory diagnosis and treatment and take her through it. So it will be a combined effort of the VIA trained nursing personnel and the faculty at AIIMS Rishikesh. So you don't need much of an infrastructure. You just need some spacious room with a couch and a light source. And manpower will be a counselor and the performer, who both will be the VIA trained nurses. And counseling is again very, very important. So they will strike up a conversation, they make the woman comfortable, tell her what it is, and also encourage them to speak. So hopefully, because we did a study at AIIMS Rishikesh, and we found that only about 10% of eligible women were screened. In busy OPDs, screening is just goes at the back of your mind, except for people like me or other people like Dr. Abraham and others who are working in this field. We screen every woman who comes to us who are eligible. Then we did an interventional study in which we had a counselor and a research officer. And once they counseled them, it went up, the screening rate went up. But when we had a dedicated room only for screening, it went up to about 70%. So that's how it led to this VIA training or nurse-led VIA training initiative. And we also saw these pictures of how acetic acid works. And to summarize, it's a ubiquitous virus spread by skin-to-skin contact, causes disease in both men and women. 6 and 11 causes genital warts and respiratory papillomatosis. 16 and 18 are persistent. And in all, it causes 7 cancers in men and women. You have primary prevention with quadrivalent and nonavalent vaccines, and secondary and tertiary prevention with HPV testing, HPV DNA testing, which is the best. But of course, you can still continue to use cytology and also visual inspection with acetic acid. So we have this conference in 2023, September. The theme being Vanquish Lower Genital Cancers, and hope to see some of you, at least of the group, in Rishikesh. And I think HPV can be eliminated provided the virus doesn't mutate. Thank you. Yeah, that's all I have to say, Dr. Vidya and Abraham.
Over to you, Dr. Abraham.
No, I think Shalini did a great job, a very comprehensive presentation, right from epidemiology, pathogenesis, screening, vaccination, and also community outreach. So I think she's done a great job. There were a lot of questions in the chat box. Some of them have been answered by, I think, mainly Puneet. But I just wanted to just make a few comments that yes, cervical cancer and other HPV-related diseases are eminently preventable because we have very good, effective vaccine as well as screening tests. So it only requires political will to implement these things and allocation of resources. And of course, policymakers will go in for the most cost-effective or low-cost interventions. So that's something that we need to work on. The Indian HPV vaccine was promised at 400 rupees. I think that was mainly for government. Right now it's about 2,000 rupees because it's in the private market. But I think if the government starts their programs, they will get it at a much cheaper rate. The other thing is the HPV vaccine is effective in both males and females. But of course, when resources are limited, it's better to vaccinate at least the females. But as far as sending the message out, it should be promoted as a gender-neutral vaccine. Otherwise, when you go into the community and say only the women should get it and all that, lots of other questions get asked. Similarly, it should be promoted as a cancer-preventing vaccine and not as a sexually transmitted and prevent STI. So I think, the other thing I was thinking was the point of care testing is very important. Point of care testing as well as the treatment then and there, because loss to follow-up is a big problem in the community. So, and I think Shalini did allude to this. So that's something that we need to work out. and of course, a good, effective point of care test is what we really need. And thermal ablation is a very good method that can be easily. Now we don't have electricity. We can even have battery operated instruments. So that should be, very useful in the community. I think, instead of trying to get the ideal, the perfect test, it is, whichever test we use, something is better than nothing. Even once in a lifetime testing is better than no testing. So, we have these recommendations by professional bodies, including the WHO. So I think WHO especially tries to give you the minimum. They say at least 1 or 2 tests or, ablation. And the question is, we have to differentiate between treating a woman in the clinic as against treating or approaching this problem in the community. Population-based screening is different from testing in the clinic. Trying to prevent something in the community is different from trying to do something in the clinic. So in the clinic, we would need a much more specific test like cytology, whereas a more sensitive test like HPV DNA testing would be useful in the community. But we have to be clear whether we are going to treat, how we're going to manage the screen positives. I know all the Shalini said that we are moving towards HPV screening, but what do we do with the HPV screening positives? If we do another triage test, the sensitivity will come down. So if you're willing to treat everybody, then over treatment, do we accept that? So I will stop here, and if there are any questions or Shalini wants to make additional comments, please go ahead.
Yeah, no
Shalini,
comments.
do you want to answer this question that given a choice, which one would you recommend, nonavalent or quadrivalent for organ recipients?
Nonavalent, of course, would be the better one, but then the cost. It's all question of, if you have the money, go for the nonavalent. If it's available and if you have the money, go for that, because that prevents, active against 9 viruses, whereas the bivalent or quadrivalent is effective in much less. So I think nonavalent would be the better one.
Thank you, sir. Dr. Venkatesh has another question. Should middle-aged males with warts in genital, non-genital areas be vaccinated? He routinely sees many male smokers with warts when examined for unrelated conditions.
See, the vaccine is most effective before someone is exposed to HPV or someone is exposed to sexual activity. Once, closing the stable door after the horses are bolted may not be a wise thing to do. But of course, since there are many HPV types, we can always argue that it may protect against some of the types that she has not been infected or the person has not been infected against. But someone with genital warts has already got 6 and 11 infection. So giving a vaccine may not prevent further genital warts. But if they have not been infected against 16, 18, it might prevent penile cancer or anal cancer or oropharyngeal cancer. But then the effectiveness is probably going to be 40 to 50%.
We have Dr. Kuganathan, who's a community medicine expert. Sir, would you like to speak out your question? Dr. Kuganathan? So Dr. Guganathan's question is that patient is negative for 6, 11, 16 and 18, but positive for others. A colposcopy is negative for now. Could we give a vaccine?
Yes, you can, but how did he test for 6, 11, 16, 18? Normally the channel gives you 16, 18, but doesn't talk about 6 and 11 when you test, and it talks about high-risk viruses. Normally in your testing, it might tell you if you do a hybrid capture that this is a low-risk virus or a high-risk virus, but only there are some tests which can tell you that this is 16, 18 and all the others. So if she's negative for 16, 18, yes, you can give it.
The other thing
but
is,
as Abraham said, it may not be as efficacious.
No, the person might have cleared the DNA. Just because the person is test negative does not mean that the person has not been exposed to DNA. So normally we do not test for before we give the vaccine. We give it to the adolescent, assuming that they have not had sexual activity so early. Whereas if someone is an older person who is sexually active would probably have been already infected, even if they are DNA negative, there's no real point in giving the vaccine. I mean, at least you have to accept that the efficacy is very low.
Right. Anything further you'd like to add, Shalini?
No, nothing. When Dr. Abram was talking about the government of India is going to ask for 400 to 500 rupees, you know what the government of India wants it for 30 rupees and 50 rupees. And that's why they told them, go ahead and sell it in the private market, make your money, and then we'll buy it from you for 50 and 30. So
that's the problem.
That's an inside story.
Yeah. I mean, that's why these things don't get implemented in poorer countries, because the amount of money that the government has to put into this is really huge. I mean, so you can't blame them. Where will they get this money from? Because they're going to vaccinating millions of women, and where is the money for men? There's no money for, they start with, even they can't vaccinate girls.
So Dr. Shalini, though you're working in AIMS Rishikesh, you obviously mostly interacting with the gynecologists who are practicing in the private sector. Do you think the gynecologists practicing the private sector whose clientele is patients who can afford the vaccine, is it being properly promoted? Is it are the daughters of the women who are coming to the clinics getting vaccinated when they are 9 and 11? I don't think my friends' kids have been vaccinated. That's why I'm asking.
No, but the private sector gynecologists are quite active, and they do recommend vaccination, and they do give the vaccination. But I think the pediatricians are more active than gynecologists. But I do see the private sector gynecologists giving it to the people who can afford it. It's definitely being recommended, I think. What about you, Abram? I think private sector, because of Foxy, and Foxy really recommends the vaccination.
I think it's still very minuscule. Very few are getting the vaccine or pushing the vaccine. But yes, I think it's much more than what it was a few years ago. And I think Puneet said that school principals, yes, in many countries, it's a school-based program.
Yeah.
I think that's the best place to catch the young girls.
I think even in India, it's going to be a school-based program. It is going to be a school-based program.
So, Shalini, I think you should do this talk to a pediatric audience, in case all our pediatricians are not already added to the, because it's not in the universal schedule like you said.
No, it is there. It is there in the pediatrics IAP schedule. It is there for, and they do, I think they do better than the gynecologists in advocating vaccination.
Right.
Actually, Shalini, I was really amazed about your discussion. And government of Tamil Nadu is actually introducing this program of vaccination, Kadasil. And some of the districts have been covered. Now, I made the question, one patient came from the western side, the European countries, 6 and 11, and 16 and 18 are negative, and other things are positive. I asked about whether they can go in for monovalent vaccination now. How to go, and colposcopy is also negative. How to go about with this patient?
So basically, you have to follow them up with HPV tests once a year.
Yes.
Because because now 16 and 18 and 6 and 11 are negative in whatever testing she's done, and the others are positive, and they are not as aggressive as 16 and 18. So she can be followed up once a year.
Okay. The vaccination will not help her.
Can be given, but efficacy will be lower. It will not be as good as if it was given before when she was sexually naive. But it will have some effect. Like Dr. Abram said, about maybe 40-50%. There would be some kind of efficacy, but you can offer it to her because it's licensed for women up till 45 years.
Okay.
The vaccine is licensed for men and women up till 45. No, for men till 26 and women till 45. Am I right? Or is it for both of them till 45?
No, up to 45.
Up to 45. Yeah, it is licensed. Yeah.
I think Government of India is also planning, and I think people like you, Shalini, can push the government with all your recommendations to the health ministry.
Already pushing, but I was so amazed to see the rate at which they won the vaccine. But they spent a lot of money into the research with Serum Institute of India. I think BIRAC and the Government of India spent a lot of money on the vaccine development.
Okay, yeah. And this current informations are to be shared with the young practitioners also, Shalini. Whatever
Right.
you said about it, especially the DNA sequencing and using this gene expert, all these things are new things that you have to come up for the young practitioners.
Right.
Thank you
Yes.
so much.
Thank you. Thank you so much. And do we have time still, or we have? You think I finished too fast? But I thought it was a very long talk.
No,
No, I think-
normally the talk is only about 45 minutes and we have a lot of questions and things. This is actually a highly specialized field. So even then your chat box is quite full with lots of compliments to you. I must thank Puneet for introducing me to Shalini, and I don't know, I think we've been going around this for a couple of months now, and then eventually we finally found a date, and thanks Shalini. I'm sorry I missed the beginning of it because at the last minute I was asked to moderate some other session, which I was made an offer I could not refuse.
Okay.
And so I finished on time. You know how it is. I tried to close it at 8, but things just dragged along.
Right.
Thank you, Shalini, for getting Dr. Abraham on board. Was Dr. Priya unable to come? Is that it?
Yes, she had some other.
All right.
Priya would have really contributed a lot because she did a lot of work when she was at the director of NIV, and she's done a lot of work in HPV. So she would have really, I think, contributed some more to this discussion.
And probably we can do a different aspect of it in the coming months. she could participate.
Yeah.
So normally Radhakrishna writes a lot of stories about every episode of Marvelous Medicine. He will post the picture, put the link, and write a paragraph or sometimes a page on the topic on Learning General Surgery Facebook page. But today he just put questions there. So Radhakrishna, were all your questions answered? If any of them are not answered, this is
to speak the truth, Vidya, today I thought, okay, I'll listen to Dr. Shalini's lectures, a very girly thing, I thought, and then I'll enjoy IPL. Remember, she upset me so much. She dragged men into this business. I never thought, when she said 4 out of 5 men, how can I count myself out? I don't know. It's really scary, and 7 men are due to HPV. I'm not aware of that, actually. I think most men aren't aware. No, I mean, so much. It's just a wonderful lecture, I should say. The visuals are so very good. It's very clear, and I haven't heard a better lecture in my life about anything, as a matter of fact. And every fact has been put out in very nice manner. But my only worry is it's such a scary thing. Why most male doctors are not aware? I don't know how many female doctors are aware of this particular phenomenon, and why is not taught at undergraduate level. And actually, of course, girls come to you, to the gynae clinics to get themselves tested. Who will test the boys? Where will they get?
You can't test boys. There is no screening test.
No, then we are an unfortunate sex then.
But not as common as cervical cancer. It's not as common.
Though 80% of boys and girls get infected, I think most of them are able to clear the infection. So it's only an unfortunate few that get the cancer, and most men, I mean, penile and anal cancers are very much less common in men as compared to the cervical cancer in women. I think anal screening is being done. I mean, especially those men who are at high risk having sex with men can go for anal screening, anal colposcopy as well as HPV testing.
Which specialists do these tests on men?
I'm not sure who does it.
If I can just interrupt you guys, we have a dermatologist, because I know our dermatologists probably see more of though
probably
specifically said that HPV vaccine should not be taken as a vaccine against sexually transmitted disease and more like a cancer prevention. But nevertheless, Nina, would you like to come in and add as to what protocol you follow? Are you there?
Yeah, I'm there. Yeah, so anal cancers are high. So anal cancers are screened sometimes by the dermatologist. If you have a project, we are in project mode, but generally we refer them to the gastroenterologist. There was a study done in UCMS where they screened MSMs for this thing, and they found a high prevalence of HPV.
So-
But we don't have a screening for dermatology as such. We have done some work on in project mode again on trying to identify HPV from subpreputial smears, but we've not been very successful in that.
So Radhakrishna, actually the ball is in your court.
I'm just wondering if there's some communication between me and Puneet in this regard. we do a lot of rectal examinations, all sorts of minor pathology like fissures and some skin tags and all that. I wonder if some of them turn out to be HPV. What should we do? Should we biopsy all these, or how actually when it comes to HPV testing in them, what is that we should do?
I think that's a very good point. We must do some kind of a POC pilot study to look for what is the actual population, especially in the high risk. And if we can develop a POC test for that, I think it will be really worthwhile.
Yeah, I think a swab test, the same swab that we use.
Anal HPV testing will be very high. I think, only men who are at high risk, such as those with multiple partners having MSMs, should be screened with anoscopy or HPV testing and anoscopy. But otherwise, general population, I don't think should be screened.
No, we do see patients every day with some bottom problem. Many of the bottom problem we can't diagnose. We can't put a diagnosis. Should these people be checked for HPV? If it is so, what sort of test we should do, and what kit or whatever, what should we do in our OPD with these men?
Nina or Dr. Abraman want to take that question?
See, the study I was referring to from UCMS, they did HPV testing, and they also, I think, did biopsies. I'm not. It's about 5 or 6 years back. This was presented at one of the conferences where they screened MSMs, but these were MSMs, and you would be surprised at the prevalence of MSMs. These are bisexual people, but they have exposure to same-sex thing. So these were, I think, the cohort was of 40 patients. I often don't recall, but they did HPV testing, and I think they did biopsies in some of these patients.
So what was the HPV test that was used, or what that could be used now is Radhakrishna's question. Shalini or Dr.
Offhand, I don't recall because I wasn't associated with that study, but in one of the conferences it was presented.
Hi, Nina. Good to see you.
Hi. How are you, Shalini?
Good. How are you? Seeing you for a long time on this platform.
Longest of times, and this is from UCMS. The study was done by Archana. I think Archana Singhal.
Yeah. Okay. So maybe a swab stick you can use, no? The regular HPV test, a swab stick.
Yeah, they did but they also did colposcopy, and I think some of the
if it comes positive, then you can do an anoscopy or a colposcope. So maybe just a swab test, and the same test that we send for cervical cancer can be used.
Again, there are hundreds of HPV tests available, but I think any standard test, there are 5 or 6, I think there are 5 FDA approved tests, but there are some other tests also like Gene Expert and C-Gene, which are very widely used. And Gene Expert is a point of care test. So that would be a good test to do. And Shalini has got experience with TrueNat. So
TrueNat.
could be.
Yeah, because it tests for the 4 major viruses which cause cancers, 16, 18, 31, and 45. So,
in case this HPV testing is positive in a male, what next do we do? Well, you have a protocol as far as girls are concerned. What is that?
Anoscopy.
No, suppose there's a lesion, then you biopsy it. And suppose the anus is involved, then what?
I suppose you can laser it or ablate it.
Cryo laser, maybe.
Thank you.
Maybe we'll have to
do Puneet and Radhakrishna.
And then Puneet, I think we should work it out as to how to proceed, because it's an interesting aspect of the thing. Yeah, right.
Might be underreported as well, because MSMs would tend to be underreported. I'm impressed that UCMS managed to get that. With the kind of stigmatization on that, I'm not sure we'll even get volunteers to do that. So like that's exactly what I was thinking. What you said is when we have suspicious lesions, we should probably think of that. I've actually never thought of that if it wasn't for this talk, So I think that's a good point you make. Yeah.
We also use acetovitamin in on the glands also. So we can, I was wondering if we can use it in the anus also. At least in the perianal area.
Yes.
Yeah. Only treatment of the anal area becomes difficult because of the sphincter. Because if you injure the sphincter, then the person will have incontinence, right? So superficially you can. So if it is a little thicker, then it's maybe difficult. I don't know. They say radiation, I think chemoradiation or radiation, but that's normally given in invasive cancer, but can also be given in high-grade intraepithelial lesions.
We use in on the genitals, we use imicomod, which is
Oh yes, imicomod is a thing, something that you can use. That's a immune modulator, 5% aldera. That's a cream. But it causes a lot of burning symptoms.
No, it causes a lot of irritation, lot of erosions, and sometimes it becomes difficult.
So once a week, maybe you can check the imicomod.
No, it's four times a week, 3 or 4 times a week.
No, Dr. Nina, we use it for vulvar cancers and vaginal lesions, and we use it once to start with, then twice a week for 16 weeks.
Okay, for genital warts, we use 3 or 4 times a week.
Okay.
But
because it causes so much of local problems that people stop it.
We also use it in bovins, which is again an intraepithelial malignancy. So we use 3 or 4 applications a week.
Okay. For vulvar and vaginal, we use about 2 applications a week for 16 weeks. Vulvar,
that's one alternative you can use.
Yes. And cidofovir is another antiviral agent, which is as good as imicomod, but has the same kind of symptoms, and recurrence rates are less because with all these lesions, recurrence rates are very high. So they have to be on yearly follow-up for a long, long time.
We also in anogenital warts use podophyllin. So that's another, and we use it not only in women and in men. We use for anogenital warts.
Trichloroacetic acid also we use during pregnancy because podophyllin is toxic. For warts, warts you can, but imicomod can be used in intraepithelial lesions also.
Imicomod is used for bovins. We use it for very regularly.
So that's your answer, Dr. Radhakrishnan, in case you find something.
Yeah, I think at least it is open.
We have also used MW vaccine, The MIP vaccine has also been used intralesionally.
What is that?
The MIP vaccine, that was earlier called MW vaccine, that we have used in anogenital warts. We've not typed the HPV in those, but then it works very well.
Right. So we've had lots of inputs, and we've had so much discussion on a topic which I thought probably go above most people's heads. So thank you so much, Shalini, for keeping the audience for more than an hour with you. Thank you, Dr. Abraham, for sparing your time to moderate the session. And thank you, Radhakrishna, for covering when I had to ditch. Thank you, Puneet, Radhakrishna, and the other, my namesake, Vidya, who logged in to make sure that everything started off well. We'll meet again next week. Next week being the last Thursday of the month, we'll have our Beyond Medicine series. And this time we're going to get a bunch of doctors who are painters to come and talk about our art. So we'll meet again next week with another episode. Till then, take care and stay safe. Good night.
Thank you so much. Thank you, Dr. Vidya, Dr. Radhakrishna, Puneet for introducing me, and Abraham for moderating the session. Thank you so much. Thank you.
And now you're going to be bombarded with our weekly flyers and links. So
that you already send it to me, na? That's how I joined. You do send it.
Thank you. Thank you.
Thank you. Thank you so much.